Fine. That is there. So I think we are all present and we can start with the session. So we have complex strabismus being simplified. That is what we are trying to make in this session. And we have very good speakers to make sure that it will be possible. And I would start with the first talk, which is by Dr. Rohit Saxena. And I think you all know him. He is the present head of the strabismus and neuro-ophthalmology at RP Center, AIMS, and a wonderful person who is going to tell us about the management of third nerve palsy, which he has himself done a lot of work on it. So, Dr. Rohit, it's all yours.
Thank you very much, sir.
Let's say that the timer, I mean, we can increase the time to 10 minutes for all.
Yes, also, I was about to come on that. So,
make it 10 minutes for all, but we will give reminder at 1 minute prior, and we would request the people to stop short at 10 then.
Yeah. So thank you very much, sir, for those kind words. And the head of the strabismus will always remain you, sir. Your presence will always be always there on our department for many years. And thank you for having me here. And much of the work I'm going to show is, of course, always being there with the presence of sir and his guidance. So I'll be talking about management of third nerve palsy. And we know that especially complete third nerve can be quite a challenge because 4 of the 6 muscles are affected, and we are quite hard pressed to actually use only 2 muscles, one of them being the superior oblique, to actually manage. But thankfully, over time, we have started getting more options, and the management options for third nerve palsy become maximal or supramaximal recess-resect procedures in the same or in the other eye. This, of course, is possible if there is some function in the muscles. The lateral rectus periosteal fixation with a large medial rectus resection. Medial globe anchor to the medial orbital wall with a large lateral rectus recession, especially to free the force suction test. And medial transposition of the lateral rectus in its various modifications. So I would be saying that more often or very frequently, we are able to manage with a supramaximal recess-resect procedure. So we must remember that in a paralytic strabismus, the commitant surgical rules do not actually apply. So the limits that you generally place for a commitant strabismus would not be true here, and you may have to do a much larger amount of surgery. So you could do the involved eye or the other eye. So if you have good movement, so you have some amount of medial rectus function showing that the eye is crossing the midline, although still falling short. So this was a partially resolved third nerve. You get a fairly good result by doing supramaximal recess-resect. The advantage, of course, is that the fair amount of motility that was there preoperatively can be preserved. The same can be used in the other eye if there is again motility in the paratic eye, if there is an aberrant innervation. So especially if the upper lid gets innervated from the misdirected fibers from the medial rectus, and you get an elevation of the lid on attempted adduction, you are able to use that by operating the opposite eye. So besides getting the correction on the deviation, you are able to augment the upper lid elevation and therefore correct the ptosis. So this is not possible if you operate the ipsilateral eye, because there is no innervational change that is happening. So the fixation durex procedure helps us to use this to the advantage of correcting ptosis. When you're looking at complete or virtually near complete third nerve palsy with very poor medial rectus function, you know that any amount of recess-resect procedure is not going to actually benefit, and any amount of removal of the tendon and even some myofibrils is not going to provide any muscle action on the medial rectus. So there we are looking at alternative procedures. We can do one option is, if there is some medial rectus function, you can completely remove the lateral rectus action. So it's like an infinite recession of the lateral rectus. It's fixed to the periosteum. The advantage of periosteal fixation is that it is a potentially reversible procedure, and I have actually had to reverse the procedure, and I could find the lateral rectus and replace it. So like I said, it can be a reversible procedure. And you can also, along that, you can do a medial rectus resection, which will help us. So here you can see that you have a very little movement on adduction, attempted adduction, and post-operatively, you can see that a reasonably good alignment is possible. And the medial rectus resection also allows us to get some adduction in adduction movement in. So of course, there will be loss of abduction because the lateral rectus is no more active now, but at least you have good primary gaze alignment and a fair amount of adduction and convergence, which can be useful in a seeing patient. However, if there is very, very poor medial rectus function, you can see that despite, so there is hardly any medial rectus function despite a large resection along with the periosteal fixation of the lateral rectus, the outcomes are not very good. So in these cases, your options now shift to the medial side, where you have two broad options of globe fixating procedures onto the medial periosteum, or a transposition of the lateral rectus, the only rectus that is actually functional, to the medial side. So the medial periosteal anchor, I prefer to use the precurruncular approach because I don't like to go through a lot of skin surgeries and all. But it's a very fast approach. You immediately get to access the medial periosteum, and then rest of the procedure is similar, like a medial rectus exposure from a limbal opening, and you can pass the sutures, make a burrow a tunnel through, and you can pass sutures from there. So this was one of the patients whom we had done a medial periosteal fixation, an extremely effective procedure. You can correct very, very large deviations, and essentially you have the advantage of this is it's fairly predictable. I would always slightly overcorrect in the intra-op period, about 10 degrees or so, to catch the exo-drift that happens as the periosteum kind of lifts up and the sutures loosen up a little. So over time, there is a very long period of stability of this and very good results, especially in very large exos, which have very poor medial rectus function. The final procedure I will talk about with multiple changes that we have seen evolve over time is the lateral rectus transposition medially, and which had been in picture for a fairly long period of time. But Gokikit was the one paper that actually revived the interest into it. And the basic problem with the medial transposition of a split lateral rectus was that the results were less than optimal. So the basic reports were there was a fair bit of undercorrection that was seen, and Jaspreet from PGI had actually recommended that combine it with a medial rectus resection, which is also a fairly good option. So the change which we did was in the medial transposition of the lateral rectus, we added an augmentation suture to the superior slip and the inferior slip. The other key thing that we also observed was that the split has to be very far back so that it does not impinge on the globe, cause pressure on the vortex veins or on the optic nerve, which can cause loss of vision or choroidal effusions in the post-op period. So it's very important to dissect almost 14 to 15 millimeters from the insertion so that it wraps around. And the other thing which I prefer to do is to take it from underneath the superior rectus superior oblique and inferior rectus inferior oblique, so that you can get it to transpose medially from a very far back period. If you have the superior oblique, your muscle will come like this and then wrap around like this. So obviously it will be tighter, tougher to mobilize to that extent medially. And you may often have to suture it much more closer to the lateral rectus and not as close to the medial rectus as possible. And posterior fixation may not be possible. So this is one of the patients of the same procedure which we did. So you can see the split lateral rectus provides some very, very good alignment. If you have a vertical deviation, you could do a full transposition of the muscle from one direction, which helps to correct the vertical. The advantage is, as you can see, this was an exo with hyper for a third nerve. We transpose the lateral rectus from inferiorly underneath the inferior rectus inferior oblique and full muscle adjacent to the medial rectus. This brought some very good vertical correction, but the horizontal correction was a little less than optimal, not as great as what we see in the split transpositions. This was from the superior. You can see the hypotropia and you can see the correction of the hypotropia, but again, slightly not so great correction of the horizontal. And finally, we realized that sometimes the results may not be so optimal with a fixed procedure. So adjustable procedure was something that we thought of. It was already being reported by Ankur Shah et al. But we realized that when they place it on the same side of the medial rectus, you can recess it, but you cannot advance it. So we used the cross fixation technique wherein the inferior slip was tied superior to the medial rectus and the superior slip tied inferior to the medial rectus, making it adjustable for both horizontal and vertical. So if you want to adjust horizontally, you advance both the slips. If you want to adjust, you have a little residual hypertropia, you adjust the superior sutures, which is actually the inferior slip, and tighten the inferior slip and bring about an increased inferior vector. So essentially, these are patients we had done for adjustable retraction. So finally, factors affecting surgical decision would be whether it's complete or incomplete. Is there any aberrant regeneration to it, where we can use that for our advantage? Is the patient actually willing for other eye surgery? Because often they are not. And finally, choose the appropriate surgery. We can see that there is some graded response of each surgery. LR to MR can help us to manage vertical deviations, mild vertical deviations in a split LR to MR, and full transpositions in a complete transposition. And I use periosteal anchor where the FDT is tight of the lateral rectus, and definitely in resurgery. So any previous surgery we have some very good results in a medial periosteal anchor. So thank you very much for the opportunity and listening.
Thank you, Rohit, for very nicely showing us the various spectrum of procedures that are available for tackling third nerve palsy. But mind you, third nerve is a very tricky muscle because it comes in various different forms. Each individual case may have to be seen differently, and depending on the force reduction test intraoperatively, one may have to decide what you would like to do. So he has nicely shown that adjustability is also possible, and on the lateral rectus Y-split also, you can put it as a cross-section adjustability, the same way that we were doing for sixth nerve. Now we are doing for the third nerve also, it's possible. So that is there. If there are any comments from any of the panelists, it's welcome. Otherwise, we will ask the next speaker, Dr. Ankur, to start sharing his screen. In the meantime, Dr. Ankur is there?
Yes, sir. Yes, I'm there. Very good afternoon. Thank you, Professor Pradeep Sharma, sir. And thank you, AIOS, for making me a part of this IC. And it is always an honor to be on dais with sir. So I'll be talking in brief about management of sixth and fourth nerve palsy. And as it was timed for about 8 minutes, I would probably like to go slow, but still it will finish probably in less than 10 minutes.
8 minutes, we'll have 2 minutes for discussion.
So I'll be starting in brief about management of sixth and fourth nerve. So we start with the sixth nerve. The symptoms of sixth nerve palsy would be a horizontal diplopia, which is worsening towards the affected site, a phase turn, a major esotropia, which is concomitant and greater in the field of action of muscle. Now, this is a case of acute onset post-traumatic sixth nerve palsy. All that is required here is just to closely observe this patient till the time the patient recovers fully. This is another case of sixth nerve palsy where the patient presents to us with sudden onset of double vision, and he has mild headache on and off with occasional vomiting. There is no other neurological illness, and we can see there is a mild limitation of abduction on bilateral sides. So probably it's a case of bilateral sixth nerve paresis, which is partial sixth nerve palsy. So on examination, everything was fine. Anti-segment was absolutely normal, but the fundus showed a florid papilledema, and neuroimaging showed a large space-occupying lesion. So it is very important to understand that sixth nerves could be a false localizing sign. So before jumping for management, we should at least evaluate them, have a good look at the fundus. So a dilated fundus evaluation is must in all cases of sixth nerve that present to us as an acquired case. Now, management options in the acute phase would be occlusion, prisms, and Botox. And 6 months later, we can think about surgical management when the stability of alignment is there for at least 6 months. Now, surgical intervention. For partial sixth nerves, we had options of MR recession, LR resection, performing an RNR procedure, and RNR can be combined with contralateral medial rectus recessions. Now, this is a case of left eye post-orbitotomy sixth nerve palsy. We can see a large scar here, which is after the orbitotomy. And she underwent sixth nerve RNR procedure for the left eye, and this is how the pre and post surgical alignment are. She has a pretty good results. This is pre and the post photograph. Now, this is another case for total sixth nerve palsy. We have options of partial vertical recti transposition with MR weakening, or full tendon transposition to the lateral rectus with MR weakening. And now we have rectus muscle reunion procedures or shifting of recti muscle to the lateral rectus with MR weakening procedures. Now, there are various procedures like Hammersheen, O'Connor, Carlson and Jampolsky's, Jensen's muscle reunion procedure, Kushner's modification of Jensen's procedure. Now, all these were fraught with problems of strangulations and of vessels and possibility of anti-segment ischemia. So then we have these VRTs, which were proposed by Rosenbaum, and then we had these Foster's augmentation suture being added to the VRTs so that we could augment the effect of transposition. And then lately we have this Nishida's procedure where the muscle is actually not split, but just shifted towards the side of lateral rectus. The superior and the inferior rectus, both of them are shifted towards the lateral rectus. In the original procedure, they were shifted, they were split, but later on it was decided not to, later it was proposed not to split the muscle. So they are shifted to approximately 8 to 10 millimeters from the limbus, midway between the superior and the lateral rectus, and both of them are just abutting the middle of the lateral rectus. Now, this can be added with an adjustable medial rectus so that we can further do adjustments in case of over and under corrections as done by Sir. And this is the case of left post-traumatic 6-nerve palsy. So this patient undergoes large recession of medial rectus along with half-width transposition of superior and inferior rectus along with the Foster's augmentation suture. And this is the pre and the post-surgical alignment. Another case, history of road traffic accident 2 to 3 years back, diplopia and primary case, and a face turn to left. So this is a case of right post-traumatic 6-nerve palsy. As we can see in the line, the right eye is not able to cross the midline. So this patient undergoes right MR recession, which is adjustable along with the superior rectus transposition. So we can see there is slight amount of abduction, which has come as I has slightly started moving in the abduction passing the midline. This is another case of post-viral 6-nerve palsy. Again, the left eye is not crossing at all, not moving at all. And this patient undergoes a large MR recession along with superior rectus transposition to lateral rectus. This is this 5 weeks post-surgery. We can see a good alignment here. Botox can also be an option to manage the acute phases. This is a case of left eye 6-nerve palsy where Botox has been given. It's a temporizing measure where we will try to prevent the contracture of medial rectus and let us so that the recovery of lateral rectus takes place for some time. Now, if in children there is no signs of neurological illness, we can observe these cases at 2-weekly interval till the time full recovery occurs. But if it is more than persistent for 3 months, then a neurological evaluation is a must. For young adults between 15 to 40 years, we should look for the risk factors. For patients who are more than 40 years of age, rule out diabetes, hypertension, GCA in little older patients, look for vasculopathies because of diabetes or hypertension. And all the patients with increasing esotropia, developing neurological signs, a detailed evaluation is a must in all these cases. Now we move on to 4th nerve palsy. This is one of the most common nerve palsies which is seen, usually congenital, post-traumatic, viral, and ischemic. It usually presents as head tilt for the congenital cases and asthenopia, vertical strabismus, and diplopia more so in acquired cases. Asthenopia could be seen both in the acquired as well as congenital cases. It is not a sign of raised ICT as it is not a pseudo-localizing sign, but it may be associated with diabetes and hypertension. Now, this is the NAPS classification which I had tried to modify, kind of tabularize. So NAPS divided various types of 4th nerve palsies from type 1 to type 7. The commonest ones seen are type 1 and type 2, and it is based upon the abnormality which we can see. So with respect to the right eye, if you talk about type 1, there is overaction of antagonist the only abnormality, that is the maximum deviation seen in the levo elevation. What is required is right inferior oblique recession. In type 2, there will be a greater deviation in the field of superior oblique, that is marked superior oblique underaction, that is levo depression with respect to the right eye. Then superior oblique tuck or inferior recession of the left eye, or a modified Harato can be done. Rarely we can have bilateral superior oblique palsies where there would be a V pattern and a torsion of more than 10 degrees, where a bilateral inferior oblique and modified Harato can be done. Now, if the deviation is in the full field of superior oblique, inferior oblique, then the deviation will be maximum in all the lever positions with respect to the right eye. And if the hypertropia is less than 15%, 25% diopters, inferior oblique recession is required. If the hypertropia is more than 25% diopters, inferior oblique recession plus a tuck can be required. So this is in brief what we can talk about management based upon the NAPS classification. So always suspect a bilateral 4th nerve palsy when there is a concussion of closed globe injury. There is a V pattern along with these 6th nerve palsy, 4th nerve palsy, a chin down posture which can again because of V pattern, alternating hypertropia in the alternate head tilt test. There is an objective torsion of more than 10 degrees and patient complaints of subjective torsion. So we should always look for bilateral 6th nerve palsy in these cases. Now, management options for congenital cases, we have to correct the head turn, so we have to plan for surgery. For acquired cases, during the acute phases, you have to plan for occlusion. Botox may not be a very good choice here, and 6 months later, we can plan for surgery in acquired cases. A brief about Park's 3 steps test. Now, this is a patient of left superior oblique palsy. Here we can see there's a minimal L over R in the primary position. So looking at this, either it is an underaction of left superior oblique or left inferior rectus, or it is an underaction of superior rectus or inferior oblique of the right eye. So as it is the left eye being involved, so these 4 muscles are in question. Now we see that the hypertropia increases in dextroversion. So the muscles left here are the right superior rectus or left superior oblique. And then when we do a head tilt, the maximum deviation is seen in the right head tilt. So it's a case of left superior oblique palsy. And hence this is how we decide on the Park's 3-step test. Now this is a case of left superior oblique palsy presenting with a head tilt towards the right side since the early childhood. And we can clearly see there is a small amount of L over R, but it increases on the dextroversion and definitely much more on dextro elevation. There is some amount of superior oblique underaction, but not much great as compared to this on the dextro elevation. So this is the Park's 3-step test. We can see there's mild amount of hypertropia, which increases in dextroversion. And on a head tilt, we can see there is significant L over R. So what we do here is a left modified iliad and Rankin's procedure, which is anterior positioning with recession. And this is the post-surgical photographs where we can see that the patient is pretty well aligned and the inferior oblique overaction is gone. And this is the post head tilt test post-surgery where we can see again the alignment is good. And this is the photograph showing you reduction in the torsion after the surgery. Now this is another patient of left 6 nerve palsy where we can see there's a gross hypertropia in the primary case and the maximum underaction is in the field of superior oblique. So this patient is planned for superior oblique tuck, and post tuck we can see there is some amount of development of Brown syndrome, which kind of gets little better, but still some amount of residual Browns remains in the dextro elevation. So in the end, careful assessment and proper choice of procedure is the key to success in paralytic strabismus. Thank you.
Thank you, Ankur, for highlighting both the managements of 6th nerve palsy and the 4th nerve palsies. As you have mentioned, in the 6th nerve palsy, there are several options, and depending upon whether the eye is crossing the midline, you may just do an R&R if it crosses the midline, or a recession and plication for the horizontal muscles, or you may do a transposition procedures. For the 4th nerve or supraoblique palsies, again, depending on the deviation in the primary position, as you have mentioned, one muscle surgery may be enough if it is up to 25 prisms of hypertropia. If it is more than 25 prisms of hypertropia, usually it will require another muscle. And that second muscle will depend upon the FDT of the eye. If it's tight, then superior rectus may have to be released. If it is not, then the contralateral IR can be done, or in a person who has a lax superior oblique, a tucking of the superior oblique can be the additional second muscle. So these are the comments, and if there are any inputs from any of the panelists, they are welcome. And anybody who would like to have any suggestions or queries, please. In the meantime, I can start sharing the screen. So if there are no comments, we move on to the second part of the complex procedures. We have talked about the paralytic muscles, paralytic strabismus. Now we have the restrictive strabismus, and more definitely now the restrictive also has been further classified into the congenital cranial degeneration disorders, and the foremost of them is the Duane's retraction syndrome. I have no financial disclosures to make. As we know, the restrictive strabismus is one which is highlighted by the fact clinically that the limitation of movement is out of proportion of the ocular deviation in the primary position, which is so in paralytic strabismus. The second thing which you can see is on the mechanical force duction test that is there. The commonly encountered restrictive problems can be several, and we will be talking about several of them in the subsequent talks. The Duane's retraction syndrome is better known as a co-contraction syndrome, and it was first described by Hugh in 1879. The frequency is about 1 to 4% of strabismus patients. The female preponderance is about 60%, and 80% of the cases are unilateral. Now, these facts, which may appear just epidemiological, have been made to appear more sensible when you go through the etiology of this, as described, as I'll talk about by an interesting article which has come up. And the left predominance is there in 80% cases. DRS is included in a group of, as I said, congenital cranial degeneration disorders. So clinical picture we'll talk about more as we go along. It may be as an ESO and EXO, but the embryogenesis anomaly. Now this I would like to talk about because this is a condition which is happening because of some problem in the pregnancy during 4 to 8 weeks of embryogenesis. Thalidomide and misoprostol use have been highlighted as problems by Miller et al. In 2009. Higher estrogen levels and the inflammation because of any reason in the mother may lead to a venous thromboembolic events, which can cause there is a left shunting effect already there because of the left carotid artery, and this dysregulated apoptosis and disinnervation can cause the female and left preponderance, which has been described. Now this is a beautiful article by Parsa and Robert in 2013. I would recommend all of you to read. It's important that we can use this information to prevent Duane's retraction syndrome in future if we can give this antenatal advice of preventing thrombogenic influences, which may be because of malnutrition, dehydration, alcohol intake, infections in the 4 to 8 weeks period, trauma, ionizing radiations, antiphospholipid syndromes, or any other autoimmune disorders which are happening. Imaging has shown us that there is missing 6th nerve in many of these conditions which we can see. And that is why we now know that it is not a restrictive strabismus, but a congenital neuropathy which is caused. Huber has very nicely shown what is the paradoxic innervation causing and how it causes the problem. In type 1, we know it is because of a lateral rectus not firing at all in abduction, but co-contracting or firing paradoxically during adduction. In fact, the medial rectus is the unnecessarily the bystander injury is suffering. The exo type, which is type 2 Duane's retraction syndrome, has normal or less abduction, which is because of the lateral rectus activity still being there, but still there is a co-contraction during adduction. And the type 3 is one in which there is a co-contraction occurring all through in adduction or even abduction. The genetic counseling is important in these children, and there have been some genes which have been identified, but mind you, they are only responsible for about 10% of the Duane's that we see. The majority are sporadic. The clinically that we'll see these cases, this may be esotropia in primary position with a face turn, marked upshoot, retraction in adduction, limited adduction because of co-contraction, and limited abduction. In the Exo-Drs, the co-contraction is still happening, but there is some LR activity. So there is an exo in the primary position, and there is some abduction also possible in some of the cases. So how do we plan the surgery? In this, basically depend on ESO, EXO, or ortho in the primary position. First of all, look at that. Secondly, look for the co-contraction. As defined, it is always there, but if it is significant, it will be seen by marked upshoot and downshoot, or it may be minimal, just causing a little retraction and narrowing of the palpebral aperture. How much is the normal LR activity is the third point you look preoperatively. And finally, intraoperatively, look for the force reduction test for MR, LR, or both. Now, if this case, ESO-DRS, we have FDT is negative, minimal co-contraction. So I have just tried to do an left medial rectus recession of 4 mm, and that takes care of the esotropia as well as the narrowing the palpebral aperture, and that is enough for this case. In ESO-DRS, a little extra MR recession may be too much. So you have to be very careful in doing the MR recession. If the co-contraction is moderate to severe, you will have to balance the MR recession with a lateral rectus recession, and preferably on a Y-split. Now this case shows you that if there is a co-contraction, then you can see there is a marked upshoot and downshoot, meaning that significant co-contraction is there. So such a case should always be in the first surgery itself added with a LR Y split, and the split has to be at least 22 millimeters between the two arms of the lateral rectus split. So in ESO-DRS, do the minimal amount of MR recession as required by the FDT. If the MR is tight, which is mostly so, and if there is a marked severe co-contraction, then add the LR recession with Y split. LR disinsertion, periosteal fixation are usually not required in the ESO-DRS cases. SRT, IRT, or VRT can be added to improve abduction, but only if the co-contraction has been neutralized. Now, this is an interesting article which has been presented by Stephen Kraft group of using a lateral rectus resection. We have been taught generally that lateral rectus should not be resected in a Duane's retraction syndrome, but they have said that in some cases it may be done, but be very careful following this advice. It should never be done more than 3 to 4 mm one, and never do and always add an MR recession. But still, in their own cases, you will see there is a worsening of the cases in the cases which have been described by them. So be very, very careful in doing this procedure of LR resection. So in Exo-Drs, if there is an taking care of co-contraction, then superior rectus transposition can be done in order to improve abduction. This is the algorithm which we follow, and we have published in IJO. You can take care of this depending upon the type of Exo-Drs that you're handling. In the second type, that is the Exo-Drs, the procedures that are available to us is the Y-split LR recession. One. Second, large 12 to 18 millimeters of LR recession without a Y-split, as usually done by the South American strabismologists. Periosteal fixation of LR if the LR activity is not there at all, and it is a very tight lateral rectus. And extirpation of LR is described, but should never be done. How much and what you should do depends upon the preoperative exotropia, the co-contraction that you see as seen by the upshoots and downshoots, and the normal LR activity during abduction. Now this example shows you, and in this case you have an LR activity. The abduction is still coming. The Exo-Drs is there. And in such a case, you would not like to sacrifice the lateral rectus by doing a periosteal fixation. So you would do a lateral rectus recession 12 millimeters or more as required by the Exo, and do a Y-split of 21 millimeters. And this one muscle surgery will suffice for most of the cases of Exo-Drs of this kind. A little LR recession is of no use. Just remember, it's a reverse of MR for Exo-Drs. It's in LR, you have to do a good amount of LR recession to take care of the co-contraction. Otherwise, it will be of no use. If there is no LR activity during abduction and there is a very significant co-contraction and a very tight lateral rectus, then the lateral rectus periosteal fixation can be done, and the abduction can be improved by a partial VRT. So here we are just tackling lateral rectus and half of the vertical recti. So periosteal fixation of the lateral rectus can be done, and this is a small clip of this procedure showing you. So limbal incision has been made. FDT was done prior to that, and now you can identify the lateral rectus. The lateral rectus is hooked. Here I am going to use 5-0 Ethibond suture for periosteal fixation. Disinsert the lateral rectus. You can cauterize this insertion point, and then use adrenaline soaked swab stick in the periosteal area. And once you have identified this periosteum in the depth, you can pass the lateral rectus, and this is how the lateral rectus turns its direction. So adjustable partial VRT is a very gratifying procedure for improving the abduction. This is a video of a person in which we have done in the right eye, and you can see the improvement in abduction after the periosteal fixation even. So this is an algorithm which is being shown. Recently, we have started doing modified Nishida procedure as for improving the abduction in cases after the LR recession Y-split or a LR periosteal fixation. And this is a pre-op and post-op of a case in which we have done the modified Nishida's procedure. And more recently, I have also done inferior rectus transposition for a case in which there was a marked upshoot or hypertropia pre-operatively, like in this case. And you can see post-operatively, the hypertropia is very nicely corrected, and this is very gratifying. Ortho-DRS cases are a little more demanding. You need to, the challenge is to correct the upshoot, but maintain the orthotropia in the primary position. And this is better handled by a LR recession with Y-split, but MR recession, preferably on an adjustable suture to ensure this. So just to conclude, the Exo-Drs cases, we will do an MR recession, minimal as required by FDT, add LR recession Y-split if there is a co-contraction which is severe. Exo-Drs cases, we do an LR recession or an LR recession with Y-split or a periosteal fixation depending upon the normal LR activity being there. Ortho-DRS cases, just to repeat, adjustable MR recession and LR recession with Y split. To improve abduction, SRT may be added, IRT may be added, depending upon the pre-operative hypo or hypertropia respectively, and a PVRT if there is no pre-operative deviation. So this is what about the management of DRS cases. If there are any questions we would like to take, and in the meantime, I will ask the next speaker to be ready. So Dr. Ramesh Kekuneya.
Yes, Dr. Sharma.
Yeah.
Should I present next?
Yeah, you can carry on.
Okay. Thank you once again for having me in this instruction course. I have been asked to present on CFEOM and Mobius syndrome, the surgical management. There are a lot of things to be covered with the evaluation as well, but I will briefly cover. It's a congenital non-progressive ophthalmoplegia, comes under CCDD. It can be with or without ptosis. It can be unilateral or bilateral, depending upon the types. Two nerves are most commonly affected because of the neuropathy. One is oculomotor, second one is trochlear nerve. There is a significant overlap in the clinical phenotypes. So genetic classification is more informative. There are at least 8 genes involved. Basically, it's classified into type 1, type 2, type 3. This is the kind of findings what you will see. In the type 1, mostly the eyes will be hypotropic. In the type 2, it could be mainly exotropic. It does not mean that there is no overlap. Only thing we need to remember is additional finding of retinal dysfunction in type 2 and possible neurological findings in type 3. We have written the whole chapter on this cranial degeneration in Hoyt textbook, Taylor and Hoyt. Autosomal dominant, you can see in this picture here. Type 1 is hypotropic. Mostly they have autosomal dominant type of variety. The type 1 can have exotropia, as you can see here, exotropia as well as hypertropia. The elevation is not usually beyond midline, and there could be a perverted convergence on upgaze. Type 2, additional findings we need to be careful. Retinal dysfunction and pupillary abnormalities. They will be usually exotropic, as you are seeing in this patient here. Type 3, mostly unilateral, but I don't see much of a neurological finding, but in the literature, it's been told that most of them can have neurological. I would present 3 cases of these types. Type 1, you can see large face turn for this patient, 35 degrees with the chin elevation, and he is fixing with abduction in the right eye. Hypertropia with exotropia, you can see in the primary position. You can see his motility-wise, there is a large exotropia with hypertropia. And you can see the elevation is defective in both sides. And sometimes measurement is not so much important. We might have to depend on Hirschberg test in these patients. Generally, I get a MRI study done in this patient. You can see on the left side, normal MRI. On the left side, patient's MRI. On your right side is patient's MRI. On the left side is normal MRI. See how thin the muscle becomes. The primary pathology here is not in the muscle, it's in the nerves. But because of hypertropia, there is atrophy sets in. You can see, other than bulky superior oblique, all the other muscles are thinned out. Because of that bulky superior oblique, they can also have hypertropia in this patient. There are some challenges in surgical management. First one, it's a fibrotic or paralytic muscle with aberrant innervation. They do not follow any laws of innervation. No specific rules for surgical thing. One of the thing here is most of them don't have binocularity. It's only we are trying to correct the abnormal head posture. They may not have a very much distorting torsion. It's always good to go for a stage surgical approach. And some of the pearls you need to remember while you do surgery is, as you can see, superior oblique insertion is nasal. This can happen in type 1 CFEMS that are already published. This is one of our patients. You can see anomalous, tight superior oblique with thin or hypoplastic. This is one of the known things. So it can, superior oblique anti-transposition can help in some of these patients with the supra large recession and resection. KIF21A patients require profound weakening of IR, that is in type 1. You should always have a counter traction for these patients. And fibrotic bands are not very uncommon. And you need to always do a FDT before. And in this patient, we did a very large recession on the right side with resection. Other side, we did a periosteal fixation with a very large. This is like nystagmus management. You can go beyond the normal number what you do. And along with that, superior SOAT has been done. And this is the post-operative picture. As I said before, you can't make it perfect, but we can make a little bit improvement, maybe 60% improvement in this patient. And this is another patient. You can see she has a chin elevation, chin up position with the face turn, with the large esotropia and hypotropia here. We did a very large MR recession on both sides with the left inferior rectus recession. This is her MRI. We always try to do an MRI when possible. It's not a must, but some patients we need to do it. And it's also rhinologist can look at the 6th nerve, 4th nerve, and 3rd nerve. And this is post-operative after MR recession and IR recession in the left eye. She has a significant improvement in both in alignment as well as abnormal head posture. You can see in this patient. And this is the last one case with the kind of mixed features. This patient had ptosis with large esotropia with tight muscles, with the correction of the esotropia as well as doing inferior rectus recession. His ptosis also disappeared after doing this surgery. Most of this based on these patients, based on your FDT findings. There are two things which can help is genetics as well as MRI. But your surgical dose, at least what I do is I will keep it in a relaxed position. FDT-based surgery is what I try to do in these patients. Mobius syndrome, I treat them. They have a abduction limitation bilaterally. They have lag of thalamus. They will have significant abduction. They behave similar to Duane syndrome, which is bilateral in terms of, I'm talking about in terms of surgical approach. And if you see Dr. Luder, he had one of the large series where he says a large MR recession is a good idea in these patients. This is what he had 5 patients with the long-term outcome. They did well over a period of time. That's one of the approach. Recently, what I do is I do a bilateral SRT in them along with MR recession, similar to what we have done for this bilateral Duane syndrome. You can see alignment as well as improvement in their abduction. That's what is surgical management. Otherwise, they just behave very, very similar to bilateral Duane syndrome, that is esotropic. Usually, they don't have any kind of fibrotic band or anything. So in terms of take clinic message, due to the nature and rarity of this disease, surgical treatment poses a great challenge to all of us. Investigating for associated neurological abnormality is important. Genetic counseling, it is difficult to get for every patient, but if you do it, it's important. We need to always go for realistic counseling because patients have a lot of expectations. But in spite of this, we might have to do more than one extraocular muscle surgery. And This improves their quality of life, as you saw in the abnormal head posture correction in these 3 patients, not a perfect alignment. Some of the comitant strabismus, nowhere we can kind of counsel for perfect alignment, but in these cases, we have to be particularly careful. Thank you so much, Dr. Sharma and AOS for this opportunity. I stop sharing here. Thank you so much.
Thank you, Ramesh, for a wonderful exposition of these complicated cases. These are one of the most challenging cases that we will encounter, the congenital fibrosis of extraocular muscles. And these are very difficult to handle. Each case has to be handled individually. I would just ask you one specific question. Cases which have a perverted convergence and still have an exotropia, what special thing do you do for these cases? Because if you do an MR recession, they will worsen the exotropia and the perverted convergence is still there. So,
yeah, you mean to say patients with exotropia and perverted?
This sort of thing, yeah.
Yeah, probably I would do, it depends again case to case, a very large LR recession plus minus periosteal fixation, but they may need a kind of inferior rectus recession in these patients. I would do nasalization of both the inferior rectus. This somehow takes care of this convergence, because when they look up, because of this tightness of the inferior rectus, that goes inside. That's one of the things I do. But in some of the patients I have seen, we might have to do a weakening of the superior oblique. It's in minority of cases where imaging will help. That's what I've seen, Dr. Sharma, in these cases.
So one is that you can add a superior oblique weakening procedure, because many a times they do not have a tight IR. This kind of condition, this is a bilateral type 2 in which the inferior rectus is not tight. It's the lateral recti which are primarily at fault, and a perverted convergence is there. So you may do a bilateral recession or periosteal fixation of the LR, superior obliques to take care of the A pattern. But have you ever considered doing a Farden or a posterior fixation on the MRs? Which
I have not done
additional convergence, mind you. If this is relieved by the release of the tightness of IR, it would be different. It would be like a vertical Duane's sort of thing. No, that is a co-contraction. But I have seen these are innervational, and some of these cases I have done a Farden on the MR to prevent this, because this is also quite bothersome when they have.
Yes, absolutely.
That's a problem. Second thing is the progressive. Any of you have seen a progressive kind of congenital fibrosis of extraocular muscles? Classically, we see non-progressive, but I have come across some children, infants, they have had a tight inferior rectus, which is progressed from their birth time, and it was only the inferior rectus which was tight. It wasn't having any cystic sarcosis or a myositis sort of thing on imaging we have seen. And I have done a disinsertion of the inferior rectus, but still sometimes it comes up. It's something innervational which is happening. So any of you have encountered, because I have seen at least 3 of these cases which are progressive IR tightness.
Yeah, couple of cases I have seen. Probably it's because of early surgery, because this cranial dissemination still can lead to some muscular changes over a period of time. That's why I think there are 2 things we need to differentiate, whether it is an undercorrection or a progressive disease. So once it is corrected, still it can progress because of the changes, pathological changes, what happens in the muscle. These kind of things I have seen. Otherwise, I don't think so. We have seen.
I'm talking about progression happening even without your intervention.
Yeah. We had a couple of these cases also, sir. One child born normal at birth for 3 months, documented photographs of the parents, and then 3 months later, slowly over a month or so, the hypotropia kept increasing. In fact, in front of us, we wanted to follow up imaging by everything. We took a biopsy also, we didn't get anything. Then we finally did the IR large recession, very good in the early post-op, came back again with that virtually the same amount of hypotropia. The second surgery was a complete disinsertion. Again, some hypotropia again came back, although not as bad. And the child is on, in fact, the last one was done just pre-lockdown, the second surgery. So we had sent him home on an alternate patch for some time, but that child didn't come back. And the other child also showing progressive even after a very, very large, I mean, as far as I could go, probably it was 9 mm IR recession, but still the hypotropia initially also remained and progressed. So not clear as to what was happening, but they were definitely born normal at birth, normally aligned.
So I think we had this report, which I think I might show you the results of that. We had to do a SR plication also as a second procedure in one of these cases. So now we move on to Dr. Sujata Guha to talk about Brown syndrome. I had clubbed the talk of Dr. Ramesh for the reason that these were CCDDs. Brown's is a little, some people would still consider as a CCDD. And we will now have Dr. Sujata Guha from Kolkata and on the management of Brown syndrome. Dr. Sujata, are you unmuted?
Unmute, yeah.
And the host, please highlight Dr. Sujata Guha. As a
divergence in upcase, that is a V pattern. It can also have a downshoot in adduction in a few cases. So the acquired cases present a little differently. They have a sudden onset. They have double vision and pain over the trochlear region, and the conditions associated could be very varied. In our country, cysticercosis could be an important cause. It could also be associated with trauma, the inflammatory processes like SLE and rheumatoid arthritis, and sometimes iatrogenically after a local anesthetic injection. So the investigations that could be done are the inflammatory markers in the blood like ESR, CRP, ANA-RA. Both CT and MRI can be done, and CT can, in cysticercosis, CT can show a nice enhancement due to the scolex, and the same can be seen on ultrasound. The scolex is a high reflective echo. However, the MRI and the CT both can be normal despite an inflammatory pathology. It might not show enhancement and thickening near the trochlea or in the superior oblique muscle. What are the treatment options? Well, we usually do not intervene if the cases are mild or moderate. We treat the acquired Browns according to the cause. And surgical intervention is reserved for patients with high hyperopia or with an abnormal head posture, which is very disabling. As I said, masterly inactivity is one of the important management. And this is the patient of Dr. Sumita's, nicely chronicled, so I'm showing it to you. The child presented at 5 years of age with bilateral duanes. At 9, both the eyes showed a limited elevation in adduction. At 17, the elevation has slightly improved, and by 28, you can see the elevations have improved remarkably. So we actually did not do anything but follow up this patient. So masterly inactivity has been one of the modality because nearly 95% in a few studies, nearly 95% have shown regression over a period of time. Now, the exaggerated traction test can also be therapeutic along with its diagnostic values. And sometimes the anomalous band between the superior oblique tendon and trochlea are broken during the traction test, and thus we can free the superior oblique. Now, acquired Browns should be treated according to the cause. In cysticercosis, albendazole with steroids give good results. In non-specific inflammation, we can try oral NSAIDs, oral steroids, but injection of steroids into the trochlear area, both dexamethasone and triamcinolone, have given good results. Even though we should actually discuss with the patient that the ocular motility may not return to full despite a good improvement in their diplopia or head posture. So this is another patient with acquired Browns presented with diplopia and chin elevation, and you can see the right eye is not elevating in adduction, and post-treatment the head posture has remarkably improved, and the elevation in adduction has improved slight bit, but it has not returned back to normal. So Injection of steroids into the trochlear region, you can see the force reduction test is showing a tight oblique, superior oblique, and the injection into the trochlea is usually a triamcinolone or dexamethasone given in the superior nasal part of the orbit with a 30 gauge needle. If it's dexamethasone, it's difficult to give triamcinolone with this thin needle. So this is a dexamethasone being injected into the trochlear region. Now, surgery is usually, as I mentioned, reserved for patients with a large hypotropia or a large chin-up posture. The different surgeries that have been advocated are tenotomy, tenectomy, tendon expander, split tendon elongation, and trochlear surgery around the trochlear area. So tenotomy is nothing but cutting the superior oblique muscle, and posterior tenectomy is cutting a part of the posterior oblique muscle. Here you can see we are showing a posterior tenectomy. The disadvantage of tenotomy and tenectomy are the development of superior oblique palsy, and sometimes the patient can land up in down gaze, which is a little more troublesome than the disease itself. So largely the tenectomy has been given up. Surgeons in the past, when they were doing tenotomy, used to combine it with an inferior oblique recession to counter the superior oblique paresis, and the incidence of superior oblique paresis can be as high as 85% in tenotomy and 50% in posterior tenectomy. Now, coming to the second option, surgical option, it is the tendon elongation. As I had told you before, the tendon itself is tight, so it does not allow the globe to move up when the inferior oblique is contracting. So if we can actually cut the tendon and elongate it with something, then the tightness will be relieved. And we can do it with several methods. The suture method, the chicken suture it's called, is a suture which is kept between the two cut tendons. Usually a non-absorbable suture like Ethibond, 60 Ethibond is used, and we put the sutures at a slack, usually 8 millimeters or 7 millimeters, depending on the force reduction test. And we cut the tendon between the two sutures. The approach can be either nasally. We prefer the nasal approach, but the nasal approach is a little more difficult because there are a lot of structures, and you can compromise the septum in that area. So here this is the nasal approach, and we have put the two sutures in a lag, and we are cutting the tendon in between the two sutures and lengthening it. Now, you can do this procedure in an adjustable fashion. After doing a force reduction test, you can check the tightness, and you can actually loosen or tighten the suture according to the results of your force reduction. Different other materials have been used to elongate this two tendons. The silicone band, which the retinal surgeons use, the 240 band has been used. Fascia lata, palmaris longus, many things have been used. However, the disadvantage of all of them are that they are all external. They can all cause granuloma. They can all be extruded, especially the silicone tendons, and they can all cause a lot of adhesion around that area, which itself can give rise to a little limitation in that area. So it is gaining popularity now is split tendon lengthening. It is nothing but splitting the tendon in a Z fashion. So here we put two clamps and split the superior oblique tendon in the middle. And then we suture and cut the one half, and we put the suture in the other half and cut the other end and tie the two sutures to form a Z. The advantage of this procedure is there is no problem of extrusion. It is just one suture knot, so the granuloma is much lesser than the other modalities. The normal path and insertion of the superior oblique is maintained. It is a reversible and a titrable process. You can also operate around the trochlear area for acquired browns. But however, any surgery around the trochlear area comes with its own risk of adhesion and scar formation in that area. So to summarize, most of the patients of browns are asymptomatic, and there is a good chance of spontaneous resolution. So a conservative approach with a wait and watch policy is a good policy. Surgeries are reserved for patients with a large vertical deviation or a large abnormal head posture. The current surgeries which are preferred are tendon expanders with either a suture or a band, 240 band. Medical management can be done for the acquired browns. Thank you.
Thank you, Dr. Sujata. I think I would just add my 2 cents on this. One is that the conservative management is fine, but this is overrated, that most of them are self-resolved. They do not actually get fully resolved. What happens is, as the child gains height, the problem is not so much obvious. When the child has to look up, it is more obvious. When he is getting taller, then it doesn't show up. I have seen some patients who still have it. Mild browns continues to remain like that, but once they are old enough and their only problem is only in the up gaze, they may not like to be operated, and that's fine. The other thing is that as far as the choice of surgery is concerned, I have basically tried most of these procedures, whether they are the chicken neck sutures or the silicone expanders. All these procedures which are done on the nasal side have a problem of causing a restriction, and secondly adhesions. And the nasal side is a very important area for strabismus surgeons. I would rather say that you operate on the temporal side, and even Kenneth Wright has said that for the silicone expander, approach through the temporal approach. I would rather go for a hangback loop tenotomy in cases in which there is a tight superior oblique or with the superior oblique overaction is there. If it is only a tight superior oblique with no superior oblique overaction, these are the cases which you may just watch if they are mild. And if there is more severe, then you can do a tendon stripping procedure to minimize the tightness which is there. So this is described by Wells, and I think it's a procedure which may be required for those particular cases. Any comments from any of the panelists?
There is a question from Dr. B.S. Goel.
Yeah.
Can a simple recession of superior oblique be done? And he says he has favorable results.
Superior oblique recession can be done, no problem. What we are doing is a controlled recession of superior oblique in a way when we are doing a hangback loop tenotomy. But whenever you are doing this, be careful that you strip or separate the adhesions between the superior rectus and the superior oblique. Okay, there is a tissue which needs to be separated, otherwise you may not get the result in spite of what you want. So the next speaker is Dr. Shreya Shah. You can start sharing, and if we have any questions, we'll have in the go. Dr. Shreya is from Dahod, and I have requested her at the last moment. She has agreed. It's wonderful of her that she has done this, but because she has a vast experience in handling trauma, and the blowout fractures and the flap tear management is an interesting thing. And I would now ask Dr. Shreya to talk about this. Dr. Shreya.
Thanks a lot, Dr. Sharma sir, for nice words, and thanks AIOS for allowing me to speak on blowout fracture. Oh, my slides are not moving. Can I take a second, sir?
Dr. Shreya, you can actually go to the main keyboard and move it. Okay. It sometimes happens with the Mac systems.
It's not moving. I'll just take, by the time if you can start your talk.
Without the slideshow, then you can go to the.
Okay, but then the surgery.
Yeah, surgery also you can.
For allowing me to talk on blowout fracture and the flap tears, and these are two publications out of our 12,687 cases. We also found that 30 to 40% of facial fractures involve orbit, and this was published in IG also. Today, we are glad to announce that out of this 15 global initiative through IGETS, this is published in Graphe Archives today only. When we go to orbital fracture that can be a pure blowout fracture or impure blowout fracture depending on the involvement orbital rim. So if you look at the floor of the orbit, the floor of antrum, it is called antral blowout fracture. It has got 3 varieties, and there can be a white trapdoor fracture in the children. So this is the type 1 antral variety when the limitation of elevation will be there. Type 2 antral variety when the limitation of depression will be there, and type 3 antral variety will have a limitation of elevation and depression both. White eye blowout fracture we all know very well, and it needs urgent repair. But why the floor is damaged? Because of 0.23 millimeter thick roof of the infraorbital canal, and that simple trivial trauma can cause the damage to the floor and herniation. So there are 2 theories. Hydraulic theory, when the object bigger than the orbital rim hits the eye, then it causes the floor fracture because of intra-orbital pressure increase. And the second is buckling theory, where direct pressure also can cause the rim to damage and cause the infra-orbital fracture. The second one common is medial wall fracture. It is called ethmoidal blowout fracture also. And it again has type 1 and type 2, limitation of abduction and limitation in adduction. So that can be right medial rectus entrap. Roof fracture needs very high velocity trauma, but it may be presented with hypoglobus entrosis. So the 4th variety is lateral wall blowout fracture, which is very rare, but it happens because of its thickest wall. There are some special consideration in children for the orbital fracture because the skull is 8 times more than the face when the child borns, and only sphenoidal sinuses are present at birth along with rudimentary maxillary sinus. So before 7 years of age, mainly orbitocranial fracture happens because the eyes are recessed, face is recessed, and the orbital rim is prominent, and they get fracture more. So in children, roof comes first, floor, and then medial wall comes. And then when there is a floor fracture, there will be always entrapped inferior rectus muscle, can be because of soft elastic bones. It is called trapdoor fracture. And with that, they will present with the white eye, without hemorrhage, without ecchymosis. When this kind of child you get, don't just jump to the surgery. Look for the CT scan, and he had a pneumocranium, so wait for the surgery. After 7 years, orbital fractures, and same like blowout first, and then cranium, and then facial. Almost all patients will have a history of trauma, and that can be taken care of by examination of vision, swelling, ecchymosis, facial asymmetry, anesthesia, around the infraorbital supply, motility disorders, subconjunctival hemorrhage, hyphema, and globe. Along with the cover test, diplopia charting, and field of binocular single vision, and haze charting to see the restrictions. Intraocular pressure in the primary gaze and limitation, all the gaze also measured, and inothalamus, exophthalmos also, and pupil also to be seen to look for traumatic mydriasis. Visual field also has to be measured along with the radiological investigation. You should order radiological investigation for the coronal with 1.5 cut, so that gives you the proper herniation guide before surgery. So as I said, children will have trapdoor fracture and adult will have large defect with herniation. But all entrap muscle will not cause the motility disorder, and all motility disorder will not cause the entrapment. So this is a force duction and force generation test helps you very much. This is force generation test positive in this person. For children, we need to do force duction test under general anesthesia. Restriction should not be just jump and conclude, because it can be just because of edema, entrapment, herniation of tissue, entrapment, herniation of muscle, flap tear, and displacement of the globe. These are the differential diagnosis. Non-surgical management can be done, and we have to see the patient every 3 days for improvement in ocular movements, orbital displacement, and inophthalmos. And treatment can be initially prisms, complete or sectorial occlusion, and sometimes patient may present with the abnormal head posture. And also we can give short course of steroid antibiotics and ask the patient not to blow the nose in order to prevent from the orbital emphysema. Indication for surgery is degree of inophthalmos, significant bone fracture, and trapped muscle, continued symptomatic diplopia, and force duction test positive. Timing of surgeries are always controversial. In adult, usually 14 to 21 days is okay. But when there are red flag signs, operate within 24 hours, like oculocardiac reflex, retrobulbar hemorrhage, open globe injury, CSF leak, and muscle strangulation. Aim of surgery is to give the complete closure of bony defect and give binocular single vision without diplopia. Routes of surgery are transconjunctival, transcutaneous, and endonasal. Material for implant available are autologous bone, titanium mesh, alloplastic like porous polypropylene, silicone sheet, and combination. And nowadays, newer material, absorbable materials are used: PLA, PGA, PLA plus PGA, and PCL. This boy had a wide blowout fracture. So after canthotomy, we should do inferior cantholysis. Then the transconjunctival incision is placed. The periosteum is properly separated, and then look for the fracture properly. Take out all the tissues from the antrum. We implanted porous polypropylene implant and attached with the cyanoacrylate glue and place. Then again we can suture the periosteum, transconjunctival root, and then canthotomy. And don't forget to do force duction test at the end of the surgery. So this is third day post-op of the same day, same boy. This boy, we need to wait and then till the enophthalmos develop. Once the enophthalmos developed, after 10 days edema regressed, then we operated for the floor fracture with titanium mesh. So on table it is seen that there is no enophthalmos. But this person, I got a call from facial-maxillary surgeon and orthopedic surgeon in our area. We usually operate together these kind of cases. So after examination of complete orbital area where the fractures lie, we tell this facial-maxillary surgeon to fixate the mandible first, and then we start the orbital fixation. So I did the medial rim of the fracture fixation first, and then the lateral rim of the fracture fixation. I'm extremely sorry for this video because my resident was clicking this video and I was operating at other place without microscope. So I had to, just to tell about all kinds of fracture, I have included this video in it. After that, proper implant after fenestration of the edges, we put, and this patient had a large defect in medial wall and inferior wall. This floor implant was fixated. After fixation of complete implant, we must do the force duction test on table. Initially in the surgery, immediately after surgery, you may feel that force duction test is still positive. So again and again, go and readjust the implant, because sometimes implant is touching to the tissue or the muscle. So till the force duction test is completely negative, that then only we can say the end of surgery. And then we fixated the superior orbital rim in this particular patient. This is post-operative 1 day and 7 day. Patient regain all the movement in all gazes. So sometimes we may have to operate in multiple areas and still we can give good results. Endonasal route I don't recommend, because as an ophthalmic surgeon, we don't like to push some tissue against globe. Complication intraoperative can be just damage to optic nerve, but with experienced surgeon, it doesn't happen because they do meticulous resection, proper measurement of implant, can use 3D printer to measure the implant. Complication immediate post-operative can happen: infection, antibiotic, it can be prescribed, edema, systemic steroid can be given, hemorrhage. Then we have to reopen and ligate the vessel. Implant migration, reoperation, and re-implant the area. Vision loss due to compartment syndrome, then again we have to reopen and decompression effect should be given. Herniation of tissue can be because of improper size of implant, so you have to take care. And complication late can come with some motility disorders, enophthalmos and palpebral fissure changes. In this flap tear, again patient presented after 6 to 12 months with the diplopia, and then recession resection procedure can be done. In this gynecologist also, we did all the correction, but later on he had a canthal tendon deformity which can be corrected post-operatively cosmetically. Sometimes iatrogenic enophthalmos can be created by floor fracture from the sinus surgery, as happened in this lady. So we treated, we did everything, but then she was not satisfied and she thought it is enophthalmos, but it is pseudo enophthalmos. So in this case, we can use the fillers area. This is last slide, sir. And this is a true enophthalmos where we needed to do all kinds of surgeries, including ptosis and volume augmentation surgery. So I'll conclude with that. Monitor regularly. Surgery for large fractures and trap muscle should be done, and muscle surgery can be done later on anytime. And in this COVID-19, we had again 2 publications just because increased injury rate. I'll tell you later on. Thanks to my patients. Thanks to my teachers. Thank you. I'm sorry for taking one minute because my slides were not moving. I'm extremely sorry.
Thank you, Shreya.
Yes,
I
sir.
think it was a very nice presentation from the oculoplasty perspective. I think we were wanting where you stopped to start from there also, because this strabismus management.
I heard that, but I thought people wanted to know all this.
Flap tears is the other thing which probably you mentioned. So these are the things which will bother the strabismus surgeons more often. And the management of the floor is usually handled by our oculoplastic colleagues, but you have done a wonderful job on managing that too. So in flap tears, I think we need to remember that the inferior rectus may have an orbital and a global layer. The orbital layer which avulses and then attaches to the floor, that causes a differential type of presentation, sometimes an elevation restriction, sometimes a reverse leash depression restriction also. So these may have to be managed, and I think Irene Ludwig has presented a very nice work, and earlier we were not having this clear understanding of the flap tears, but the identification of the flaps and resuturing does a great job. But I think short of time, we may not be able to say that, but in blowout fractures for the strabismus perspective, I may just add that we need to monitor the binocular vision fields, because many of these will have elevation and depression, both limited, and in the primary position, they may be okay. And we just need to monitor once the edema settles and they are okay. Then later on, if still this bothers them, sometimes we may have to look for the FDT of the inferior rectus and go into the same eye. But otherwise, if everything is free, then we may just manage by a contralateral vertical rectus surgeries by doing a Farden on both superior and the inferior rectus to increase the fields.
Yeah.
Now we have the last talk, and I think we will just be, I'll be sharing my screen. So this is the tackling the aberrant regenerations. Part of it has been covered by Dr. Rohit in the aberrant regenerations in the third nerve, which is very commonly seen. Now, this case shows you that in the primary position, the eyes are actually straight. It's only the lid which is a problem. So in such a case, I may not be doing much, just to counsel them and send it to an oculoplastic colleague to handle the lids. But cases in which there is an exotropia along with an aberrant regeneration may have to be counseled, and if they agree, you can operate the horizontal recti muscles in the normal eye, so-called normal eye, or the contralateral eye, to do the fixation duress surgery in order to lift the lid like shown in this case. And this is another example of a 20-year-old male who had this aberrant regeneration, and after the contralateral surgery of LR 15 millimeters and medial rectus plication 8 mm, you can see the correction of the exotropia along with the lifting of the lid in the primary position. So this is another thing which you have to keep in mind. Just analyze, find out the misinnervation, and then correct the misinnervation. If it is not possible to correct the misinnervation fully, then we have to limit its ill effects. Like in Duane's retraction syndrome, you have seen we do it. The same disinnervations are the hallmark of the congenital cranial disinnervation disorders. Most of these CCDDs are having a primary misinnervation of lack of that innervation coming to that nerve, the muscle, and the secondary misinnervation in the form of a aberrant innervation which is happening. A classical example is Duane's retraction syndrome, which you see the paradoxic innervation which is coming to the lateral rectus during adduction. In synergistic divergence is another example of a aberrant innervation in which there is a innervation which is coming instead of the medial rectus, it goes to the LR, just the reverse of what you see in DRS, and that is why some people label it as type 4 DRS. So synergistic divergence, if you see this child, now the moment he looks abduction, you can see there is a further abduction impulse which comes in the eye, which was missing in the primary abduction effort. So these are complicated cases. How do you manage? One option would be to do a periosteal fixation of the lateral rectus, which we used to do earlier. But nowadays, now we have got more confident in doing the LR Y split and medial transposition. That I would say is the choice procedure as if it was made for this condition. So a congenital third nerve palsy with a synergistic divergence, if it is there, you can, this is a pre-op, and sorry, this is the post-op of the case after doing, this is the bi-split showing you. Yeah, we can have this LR to MR transposition in synergistic divergence. The lateral incision has been made, limbal incision, the lateral rectus is identified and split. Splitting is always going to have a little bleeding, which these strabismus surgeons don't want to have, but this is an unnecessary outcome of this. You need to split at least 20 millimeters or even more. As I said, even 20 millimeters sometimes can cause a uveal effusion syndrome. And then you bring it underneath the inferior rectus, which also means underneath the inferior oblique, and then again underneath the superior rectus and the superior oblique. And once it comes on the medial side, you identify the medial rectus. Now these sutures have come. I am showing you the cross-section type of a procedure in which you can adjust it by using the cross-section and vectorizing the force much more. So we do not get under corrections with this type of technique. And that means the superior half has come inferiorly and the inferior half of the lateral rectus has come at the superior end of the medial rectus. And these can be intraoperatively adjusted if it's a child. And then we go by the deviation in the under the microscope. But if it's an adult, we can do it as an adjustable procedure 5 to 6 hours later. So after the lateral rectus to MR transposition, which has been done, you can see the correction is there as well as an improvement in adduction which comes in. Now this is another case which is showing you a synergistic innervational downshoot. Now this we have described as a SID syndrome. On attempting right adduction, notice that there is a downshoot of the right eye, as if looking towards Tokyo and it goes towards Sydney. So this is what is abnormal innervation which is happening. And this is a post-op. Now what you have found here is that there was an innervation coming to the inferior rectus instead of adduction. So the inferior rectus actually should be working like a medial rectus. And this is what, once we identify, we transpose the inferior rectus to the medial rectus side. And you can see that the downshoot gets corrected as well as the adduction improves. Now on adduction, you can see the right eye, the downshoot has gone and the adduction has improved. So this is like targeted strabismus surgery. Doing MRIs which are dynamic, that means in different gazes or kinetic MRIs, in dextro gaze in primary position and in levo gazes, you can confirm what you are suspecting the misinnervations. As you can see here, the lateral recti are co-contracting on the dextro gaze. And primary position, you can see the lateral rectus is much thinner. On dextro gaze, on the right side picture, you can see, which are circled with the red circles, you can see the width increased. That means there is a co-contraction of the lateral recti in dextro gaze. This confirms a synergistic divergence. And on the levo gaze, you see on attempted adduction of the right eye, the inferior rectus is now acting or innervated. And this would mean that the inferior rectus is working during adduction. We just transpose the inferior rectus on the site of MR and it does the trick. So this is the strategy that we follow for aberrant innervations. So we need to be chopping intelligently, as we say. And these cases are some complex problems which we deal with. Some have already been talked about. Just show you some slides of the, like Mobius. Remember, it's a condition which may not have a classical secondary misinnervation, but it has fibrosis of the medial recti. And so it has to be done individually again. And the imaging shows that there is a missing 6 nerves or even a pontine hypoplasia. There is an associated 7th nerve paralysis also. Congenital fibrosis of extraocular muscles imaging, Dr. Ramesh had shown. You can see not only the orbit, but even the 3rd nerve missing if you do a MRI imaging of the area of the midbrain. This is another case of a pre-op and post-op of a congenital fibrosis of extraocular muscles. Now see the exotropia, which is marked in down gaze, and an esotropia in up gaze, which is happening because of a partly because of a tight inferior rectus, that there is a slippage of the globe, but also a secondary disinnervation which is happening. And these cases sometimes may require a Farden on the medial recti to prevent this secondary innervation, the perverted convergence, like another case of this. Some cases may have missing muscles. I don't know why the reviewer told us that it is actually a CFUM. I saw that all the muscles were aplastic or hypoplastic in this case. And finally, this progressive kind of CFUM, which I was talking about, this child who has a progressive CFUM, and this has been finally tackled by disinsertion of the inferior rectus and application of the superior rectus. Sometimes we deal with very weird exotic cases like the Goldberg-Shprintzen syndrome, which may have congenital aplasias. This is having a scaphocephaly with sagittal cranio-dysostosis with frontal bossing. And when we examined the eye, there was marked exotropia. The medial rectus was found absent. In such cases, you have to then use your special cap of thinking and what to do. So here I have done a cross-action PVRT, partial vertical rectus transposition, to improve the adduction. And this gives us the good results of correction of the marked exotropia which was done. And the superior oblique overaction required the superior oblique to be weakened by PTSO. So this is what I would like to stop here and have a few minutes to talk over. And if there are any questions, we may take up.
All right, Dr. Pradeep, there is one question from our attendees. He's asked from Dr. B.S. Goel. He's asking, can a simple recession on SO can be done? I have favorable results.
Repeat, what simple? Recession of
I think that was done for Brown's. Dr. Ankur had talked about it.
We talked about it. We already said the superior oblique recession can be done. In fact, the hangback loop tenotomy is also a form of recession. It's like a hangback recession of the superior oblique. And I had mentioned that you can do it, but you need to separate the attachments between the superior rectus and the superior oblique. Secondly, the superior oblique would get automatically more anteriorized. And you have to be careful when you do this procedure that sometimes some of these cases, if you have not separated it properly, adhesions form on the nasal end, it would cause inhibition of depression in abduction. So you have to be careful about that.
All right. As we are running a little short of time, I would request Dr. Pradeep Sharma to please conclude in next 2 minutes so we can hand over the session to our next speakers.
Sure. I would like to thank all my panelist speakers and all the other people who have taken care to attend this session, and especially Dr. Goel, who has asked this question especially. So thank you all for taking interest. Dr. Rohit, Dr. Ankur, Dr. Ramesh Kekuneya, Dr. Sujata Guha, Dr. Shreya, all of you, a big, big thank you for. And thanks for keeping the music alive in strabismus. So this is the strabismus IC, the strabismus music. Thank you all.
Thank you, sir.
Thank you, sir.
Thanks a lot.
Thank you, sir, for the opportunity.
Thank you.